So this seems like a really big deal here. You're saying that 70% of patients with cancer are not getting the drug doses that they need.
What I'm saying is there's a class of very toxic drugs out there. And the numbers are not actually known because we haven't been measuring these. And it depends very much on the protocol. But the effort is to always err low instead of high. And so until we actually measure across large populations, we won't know how prevalent it actually is. But it is a large number.
So why are we not measuring?
We're not measuring because there have not been routine tests at one level. The clinical trial process is really not geared to do this. You really like to have a very simple protocol, and people feel that measuring up to toxicity is the best way to go.
Measuring up to toxicity. So
yes, and so doctors will often say, I know when I see toxicity. And interestingly, the new biologics tend to be a lot less toxic. And so there's no index of when you've given too much, like Gleevec.
So what can we do about this? I'm not quite sure how we can create a solution.
What we need to, well, the technology to measure drug levels is implemented today in phase 1 trials already. That's how they figure the right dose.
Right.
What we need to do is have an interest in actually measuring levels in patients to ensure that they're actually getting the right amount. This can be both taking existing drugs where we can actually make them better, as in the case of 5-fluorouracil.
Right.
And setting up laboratories actually to measure these levels. It's currently done with epilepsy, some antibiotics, and other drugs already today.
And I just want to try and understand one point you said there. You said something about lots of trials fail at phase 3. Just tell me that piece again. I don't think
so in phase 3, where you're testing the largest number of patients.
So just tell us what phase 3 is.
Phase 3 is the last stage before you come out into the public. You're trying to show that the drug is efficacious. And so you pick a dose that you believe will not cause any adverse events, but it's just enough to be efficacious.
So why are they failing?
They're failing because in a population where you're going to have variation in terms of the amount of dosing, if you're picking a dose that's it's the same for everyone, even if it's adjusted for body weight, you're always going to have people that have too little drug because of the variation.
So we're using the same dose in people, not thinking about how we need to adjust it each time, and therefore it's not getting in the therapeutic window, and therefore they're failing.
So as a result, we're seeing half the drugs fail. In many cases, it may be simply because we didn't push the level high enough, because we were trying to avoid, in this one-size-fits-all scenario, toxicity for a small subset of people.
Well, it sounds like a big problem we need to think about. Steve, thank you for your time.
It's addressable. Thank you.
Thank you.
Thank you.